Good morning, everyone, and welcome to the Washington Post Intelligence Weekly Briefing. Every Friday, we bring together our analysts and thought leaders across sectors for a single purpose: to get smarter faster. I'm Luiza Savage, editorial director of Washington Post Intelligence, and if this is your first time joining us, WP Intelligence is a new kind of media. It's built for executives and policymakers who need insight to help them see around the corners of policy and industry trends. Our subscribers receive concise intelligence reports with actionable recommendations across AI and tech, energy and climate, global security, and now healthcare. We have a graphics library, exclusive executive interviews, and these live briefings where we sort out developments that are changing the business and policy landscape. And today marks our first healthcare briefing as we deepen our coverage in this very important area. At WP Intelligence, we've been covering and discussing many dimensions of artificial intelligence and its impact on everything from energy use to the effect on the economy to cyber threats. And we invite you to check out our growing archive of briefings on our platform and on our YouTube channel. But today we're looking at AI and healthcare, and specifically how the federal government is seeking to remake the US healthcare system with major investments in AI-enabled technologies. We're going to discuss two specific initiatives that we've been covering in our report: a new rural healthcare fund that is being used to incentivize AI and tech adoption, and a major new pilot project aimed at bringing AI-enabled tools, especially wearables, into Medicare. And as always, we're going to unpack what this means for industry, for investors and consumers and policymakers. And we're going to take your questions because we want to be as useful to you as possible. So to unpack this very high stakes and rapidly evolving topic, we are joined by two people who bring a wealth of insight. I'm very excited to introduce our new lead healthcare analyst, Rebecca Adams, to her debut briefing. Rebecca joins us from KFF News, and she's been digging into what the administration is up to when it comes to transforming the healthcare system using AI. Welcome, Rebecca.
Thank you, Luiza. And thank you especially to former CMS Acting Administrator Andy Slavitt for joining us today.
Yes, so Andy Slavitt is our special guest today. He is the former CMS Acting Administrator in the Obama administration, a former senior advisor in the Biden White House, and is a co-founder of Town Hall Ventures, which invests in companies that transform access and equitable care for underserved Americans. And he's joining us from Los Angeles. So thanks so much for being here, Andy.
It's great to be with you and your audience today.
Absolutely. So here is how we're going to organize the next hour. First, we're going to talk about the interest that the Trump administration has taken in AI and its potential to transform healthcare. And we'll focus on how it's using a new healthcare fund to catalyze private sector investment and rural health transformation. Second, we'll talk about a new pilot project that is aimed at transforming the use of AI in Medicare and why that could have follow-on effects across the healthcare system. And third, we'll discuss how the health tech industry is responding to these developments and where they see opportunities. And as always, we'll discuss how business leaders and policymakers should navigate this moment. And I'd like to thank our audience for the large number of truly intelligent and smart questions you sent in ahead of the briefing. We have used them to help shape this conversation, so thank you so much. And throughout our discussion, I invite you to drop your questions and comments into the Q&A tab, and we'll take relevant questions as we go along. So without further ado, let's get into it. Rebecca, you recently wrote a report called "Why Tech Companies and Venture Capital Firms Are Suddenly Eyeing Rural Healthcare," which took a close look at some significant moves by the federal government to leverage a $50 billion fund, that's $50 billion, created by Congress, aimed at shoring up the rural healthcare system that is facing major Medicaid cuts. So tell us about this money, where it came from, and what it has to do with AI.
Yeah, so thank you to everyone, and thank you to our audience for joining us. So this was part of President Trump's tax and spending law, which passed this summer and was signed on July 4th. And the idea was that this $50 billion, which is a lot of money in rural healthcare, would mitigate some of the cuts in the tax and spending law. There are about $137 billion in cuts for rural America in that law. And there has been tremendous interest in this. All 50 states have applied, and we will hear by the end of the month which states get awards and how much they're going to get. We already have some ideas, but we will get the final numbers by the end of the month. And it's interesting because this initially was posed as something that would be a rural hospital fund, but by the time the law passed, after negotiations with the White House, then it really referenced technology in a couple of different ways. And it's been implemented by the Centers for Medicare and Medicaid Services in a way that really emphasizes tech. So this is something that's generated a lot of interest.
Mm-hmm. And Andy, you know this area very well from your past experience as the acting administrator of CMS. The current head, Mehmet Oz, said these new funds will, quote, allow us to right-size the healthcare system in all kinds of innovative ways, and many of those innovations will spill over to suburban and urban America as well. I wonder how you interpret those comments. And give us a sense, is this a big deal, this money and this new direction from the administration?
Well, Rebecca, and thank you for the question. This is really a big deal. First of all, AI in healthcare is becoming a big deal in and of itself. In most of the technology revolutions that we've all experienced, whether it's computing or mobile or internet, healthcare was really last to adopt any of these innovations. And with AI, healthcare is one of the fastest adopters of technology, twice as fast as the general economy. And I think this $50 billion is going to be an enormous shot in the arm to investments in AI and in technology. And I think when Dr. Oz says right size, what he means is you've got a lot of Americans, particularly in rural America, but also in urban and suburban America, that don't have access to medical care. And there just aren't enough doctors and nurses anymore to treat people where they live. And one of the answers to that is technology. And what AI is able to do increasingly, and I think the promise is there to do even more, is to be able to get people access to medical care through agentic AI in ways that they haven't been able to have access before. And I think that's very exciting and very promising.
That does sound very promising. But Rebecca, you reported that one of the reasons Congress authorized this money was to prevent rural hospitals from closing. But in your report, you write that it won't necessarily have that effect. Can you explain that?
Sure. So there are a couple of things. One is that the law actually puts a cap on how much hospitals can receive. There's a 15% cap that hospitals cannot get more than that for clinical care. So a lot of the things that Mr. Slavitt just talked about are factoring into that, because there's a lot of revenue there for other players to get into this and to provide care to patients that need it. And one thing that I found interesting is that not only is it not just for rural hospitals, but some states are interpreting it in a way in which they actually might be facilitating the sale of hospitals. It's sort of the opposite effect of what you would have expected. One state in particular, Arkansas, has put money in their proposal to facilitate the acquisition of hospitals by another organization. And the hospitals could use this money to improve their property or to scale back some of their space. So it's just interesting the way this is being interpreted.
Mm-hmm. Andy, you have such an interesting perspective on this because you were both a former administrator of CMS and now you're an investor in healthcare companies. So talk about how you see this influx of funding potentially changing the way that people in rural areas get their health care. Do you see it becoming more virtual care, more reliance on technology? What's the end state here?
Well, I think the future is pretty wide open and pretty exciting. You have, as you say, virtual care. You also have um, remote patient monitoring, which are essentially wearables that can help keep people healthy. And I think the theme of this administration, and I think the kind of proposals they and the states are going to respond best to, are the things that change the way care is delivered. I mean, you have um, right now you have um, uh, AI that and healthcare where you wait for people to get sick. If the only thing in town, if you're in rural America, is an emergency room in a hospital, that's where you're going to get care. And if there's very few resources to help you get healthy and stay healthy, manage your chronic illness and so forth, then it's very hard to do that. So AI is, I think, going to be a very significant factor, along with this capital from the administration, to get people before they get sick and really, hopefully pay for the kinds of things that they'll use to stay out of the hospital. And like everything else in our life, will become more virtual, or a mix of virtual and in person than just in person.
Mhm. Rebecca, I think it's worth explaining why rural health in particular has been a concern. You had this really striking chart in your report that I thought we could share. And it shows that rural America now sees more deaths than births. Can you talk a little bit about some of the challenges in rural healthcare and where could technology realistically be helpful?
Sure. So as you can see, the population of rural America has been shrinking in many places. And this chart really talks about how urban America's replacement rate compares with that of rural America. We just don't have enough babies being born to compensate for the deaths. And what I found striking also was there is a gap in the mortality rates in rural and urban America, and it's been getting worse. If you live in a rural area, your chances of dying from something like cancer or heart disease is worse than if you live in a city. And so what Andy has been talking about is really what we're trying to decide here, what the stakeholders are trying to decide and the government is trying to innovate on. Can technology help? Can technology help keep people healthier and bridge that gap?
Mm-hmm. And Andy, you mentioned this is different than the traditional model of fee for service. This is based on how the patient actually fares, right? If they get healthier or not. How does that work through a payment model? And secondly, we're supposed to see CMS announce awards to states by the end of this month, and then the states will distribute the funds from there. What will you be watching for?
Yeah, look, I think there's a large variety of strategies taken by the states in their applications. And I think the states probably only have a very hazy idea of how they're going to allocate those grants when they get allocated. As Rebecca said, the first step is going to be to allocate the money to the states based on their applications. And then the states are going to go through a process which will presumably take some part of 2026 to decide how to allocate those funds in their states. And as Rebecca rightly said, different states have slightly different strategies on how they're going to do that. I expect with all this money, there's going to be a bit of a feeding frenzy. Every technology company will all of a sudden be a rural technology company. Every healthcare entrepreneur will start flocking to rural, and I think that's by design. I think not for nothing, you've got 100 senators in the Senate, and you've got 100 rural senators. That's the way it's designed. That's the way our country was designed. And so there's always been a certain amount of protection for rural health care. As bad as it is, it would be way, way, way worse if there weren't some of the protections in place on how rural hospitals get paid, on how rural communities get protected. And indeed, part of the job of the Congress, and indeed the Senate in particular, is to make sure that people who live in rural America still get access to basic services. They're taking this one step further and saying, don't just give people basic services because that's only going to last so long. Change the way care is delivered in these communities. And that's the mandate. And if people can step up to that, if entrepreneurs and businesses can step up to that, if hospitals and health systems and physician offices and clinics can step up to that, there will be indeed a lot of positive change.
Mm-hmm. And we have an audience question I want to throw to you, Andy, and I do want to encourage the audience to keep sending their questions into the Q&A tab. The audience member asks, how do startups in particular tap into the $50 billion rural health fund?
Yeah, this sort of reminds me of pandemic era funds that were going to small businesses, those loans, where you're going to get a lot of this sort of interest, and the answer really is through the states. There are states will have, as we'll know by the end of the year, some amount of money allocated to them, and we'll know a little bit more about how they're going to allocate them. And then I think there's going to be, 51 or 57 if you count territories. I'm not sure how much they're included in this, different allocation decisions. And I think startups are going to be wise to work with those states, and whether it's the state that they're in or the state that has the specific strategy that may speak to what they do. If for example, they're a startup, there's a company called Nuna Health that does blood pressure, keeps people healthy who have high blood pressure. If there's a state that has specific strategies around keeping people healthy so that they don't get heart disease, which is an enormously important thing, then you'd expect them to be, this particular company would be focused on those states that have really expressed that in their applications. So I think there'll be a lot of reading going on to see what states have what strategies. And I think then the startups will have an opportunity to say, hey, I can provide a solution to that very specific strategy you laid out.
That is great advice. Rebecca, we have this audience question. Who will represent the state's interests in spending the Rural Health Fund in a way that modernizes public health while also including rural areas that don't have broadband? Is input taken from rural health clinics, farmers, and critical access hospitals? Are members of the Senate the speakers for each state's rural health concerns?
So as Andy laid out, this really, the money flows to the states, and then the states will decide how to distribute that money. So it's really the governor's office that's going to distribute it. But I think it's never a bad idea for people who have a concern or a question to be in touch with their elected officials in the Senate and in Congress. The point about broadband is a really interesting one, because there is a limit in the broadband capacity in a lot of these areas. It's a real problem. And it makes technology a challenge when we're trying to use that as the solution. One thing that I found interesting in a conversation with another former CMS administrator, Seema Verma, was that she said at the company where she is now, Oracle Health, that they're going to be partnering with Starlink in order to provide some satellite capacity. So people are thinking about this, but it is a real obstacle in some areas.
That is so interesting. So more opportunity for tech beyond tech health to get the tech health working. We have a follow-up question for you, Andy, that came in through the Q&A. Is there a particular office or role at the states to contact? I think people really want in on this. How would you advise them to proceed?
Well, like everything else, it's clear as mud. There is, at the big states, there will likely set up offices, and there may be very specific jobs for allocating these roles, and that may be true in some of the small states as well. But in smaller states with fewer resources, they may be managing this out of their Office of Managed Care or their Office of Health and Human Services, or even their Office of Public Health, depending on how they view it. I think it'll surprise people to hear this, but it's not easy to spend this kind of money for states, and states often are very worried about getting it wrong. And indeed, as I talk about with the pandemic, and as evidence shows the pandemic, a lot of money was wasted, and there was a lot of fraud and a lot of other sorts of issues. So, states are going to have their own strategies, presumably, and hopefully they'll get together and develop some best practices on how they're going to do this. But as of now, I think it's going to be very much state by state.
There's another follow-on question. It sounds like members of the public could read the state's proposals. How does one do that?
Well, that's actually an interesting question because they're not public. Some of the states, many of the states have put them on their website, but there's not a repository on the federal website for every single state application. But you can go to your state's website and look for the application there. There also are some outside groups that are tracking this. And if you look at my report, you can get links to that.
Fantastic. And we will include a link to Rebecca's report in the email that we'll send you after the briefing. So we'll make sure to call that out as well. So one more follow-on question here. Is there funding for rural mental health care, and what are the greatest areas of need? So does this proposal also extend to mental health?
Well, it certainly can, and it certainly can, and it certainly should. I mean, when we say health these days, we should always mean physical, mental, behavioral, all as one package. And I would really hope that when states are allocating this capital, that they're really thinking in terms of the whole person, physical and mental health, because as we've come to learn, and as certainly the younger generation knows better than we do, it's all one and the same. It's all equally important. You can't be physically healthy if you're not mentally healthy. You can't be mentally healthy if you're not entirely physically healthy, 100%. So let's hope so. Different states are going to have different philosophies, but I expect there will absolutely be a thread of mental health care taken care of across many, many states.
Oh, that's great. So we've been talking about rural health, but another area where the federal government is now turning to AI is Medicare. And Rebecca, your second report that you published for us came out this week, and you are looking at an important pilot project that Medicare is launching that could have potentially sweeping impacts across the healthcare system. We called it Medicare Takes a AI, quote, big swing, which was a quote from one of your sources. Tell us a little bit about the big swing.
Yeah, so currently traditional Medicare, which is the original fee-for-service part of Medicare that covers about half of beneficiaries, it doesn't pay for things like wearable apps or mobile devices. And this is an attempt to get at that and try to provide a payment pathway for that. So it's a 10-year project, and it's run out of the Innovation Center at CMS, and it will pay referring doctors an amount to send a patient to another organization, and the other organization will get paid maybe a monthly fee, maybe some other recurring fee to manage that patient's care. And they may get a bonus if the patient's care or the patient's outcome improves based on how that person started with the initial baseline. And it's kind of based on, if the second organization and enough of their patients improve, then they'll get this bonus. The details we're still waiting to see all of the details, and Andy probably knows a lot more about this than most people. But it's really an attempt to use value-based care to try to treat one of 4 categories of conditions that CMI is looking at.
Do you want to walk us through what those 4 are for context?
Well, I can let folks know that it's mental health, like depression or anxiety. Then it's early kidney, cardio, metabolic care, like prediabetes or obesity. And then those conditions as they are developed further, like when it goes into full-blown diabetes. And then the 4th is certain types of chronic care, chronic pain.
So Andy, can you talk a little bit about how this plan, which is called Access, how did it evolve? And CMS, I understand, has been working on this issue for some time.
Well, very often, how often do we sit back when government releases some new program or new release and go, "Oh, that's cool. This is actually kind of cool." What they're actually saying is a couple things. First of all, they're saying we're going to pay to keep people healthy and keep people's chronic diseases managed and improved, rather than wait to pay only for when they come to the doctor or go to the hospital or go get a surgery or go get a prescription drug. That's a whole new category of payment. And I think we would all agree that keeping people healthy is one of the solutions to our very stuck healthcare system that's causing us so much grief, costing us so much money, and causing people to get low quality and low access. Now, the question is whether and how technology can solve those problems. And what the administration is saying is that they will pay if someone is referred to a technology and the technology improves, as Rebecca said, the baseline, so improves either the blood pressure or the weight, or it may be the anxiety or depression self-reported scores, then you can actually get a payment if you can demonstrate an outcome. So they don't want to pay for things that don't work. That would be a trap. But they want to pay for things that actually can demonstrate that if a patient starts using this, then they will see improvements in that measurement. So it's very, makes a lot of common sense. I think any of us could hear this and go, okay, yeah, that makes sense. But it's incredibly innovative. It's very different. It's a very different way of looking at the system. And I think entrepreneurs and the healthcare system ought to be excited and get engaged in it.
Mm-hmm. And
Andy,
Rebecca,
before we, I'm so sorry. Before we jump in, can you tell us a little bit more about what kinds of organizations might be able to get that regular recurring payment? Can you just kind of fill in the gaps
Sure.
there for us?
Well, let me use an example again, and I'll use the same company that I referred to earlier, Nuna Health. What they do is they have an agentic AI app that people who have hypertension, high blood pressure, who are at risk for major heart disease, if they give them a wearable device, some incentives, and they help them lower their blood pressure. And so if I were going to go into my doctor's office and my doctor noticed that I had high blood pressure, normally what he might do is say, or what she might do is say, here's a medication, here's a prescription, and be done with me. In this case, now what the doctor could be inclined to do is say, hey, let me refer you to this program called Nuna Health, and if you go onto this program, they will work with you to lower your blood pressure. They will work with you on all the kinds of things that do that. And Nuna Health, of course, only gets paid if your blood pressure improves. So it's a win for the government. It's a win for the patient. It's a win for the doctor because they don't have the time to manage all of these conditions. So, there should be hundreds and hundreds of companies like this that will be listed in a directory that'll be available to physicians and to Medicare beneficiaries that each solve one of the four problems that Rebecca listed.
Mm-hmm. Andy, we had another audience question that's quite related to what you were just talking about. And they're asking, will provider organizations be able to participate in the OAPs alongside an access vendor? So shared risk, shared upsized, and in addition to the co-management incentives.
Yeah, I think so. I mean, I think as Rebecca said, the details remain to be seen. But I think many provider organizations have their own technology and their own applications that do this very thing. And I think there's no reason why they can't, or even states for their populations can't use that technology to do that very thing. I think so. You'll have, I think, as this gets developed and in a steady state, I think you should have an array of technology companies that are available to people When people don't have that capability, when hospitals, health systems, clinicians don't have that access, because you can't have a technology for every problem that exists. But I think for those that do exist, I see no reason why they shouldn't be able to participate as providers in that program as well.
Rebecca, one of the notable items I read in your report is that this program will rely heavily on the use of wearables, and that the FDA is planning to waive its reviews for some device makers. Can you explain why that is? And how will the FDA ensure that devices are safe and effective?
I found this really interesting. This is called Tempo, the Tempo pilot in the Food and Drug Administration, and they put out a little bit of information in a notice, and we'll be putting out some more information as well. So they said that they will choose 10 companies from each of the 4 categories, and those organizations can bypass the normal pre-market authorization or other reviews. And it is very interesting. They will be providing real world data that is collected as part of the Access Medicare model. So that will be available, but they would not be going through the entire pre-market authorization process and review process that checks for safety and effectiveness. So it was very interesting to me, particularly that they were thinking about doing this for conditions that are serious, like diabetes and heart disease.
Andy, the audience is asking an interesting question. Although Access is a 10-year model, it seems like one risk is that CMMI could pull the plug early if it doesn't appear that it will result in savings. Because Access is dealing with management and not prevention of chronic disease, it seems possible that it may be cost effective, but not a cost saving program. Do we have a sense of how the benchmarks to determine cost savings will be calculated? And what are the risks of CMMI pulling the plug early, maybe?
Well, that's a really good question. It's one that's, and at one level, conceptually difficult to answer, because if you are reducing someone's blood pressure or their A1C, which is how people measure and screen for people who are diabetes or pre-diabetic, you're saving money sometime way out into the future. Oftentimes, you're preventing a heart attack, you're preventing some of the complications that happen with metabolic disease, like kidney disease and other things. And it's very hard to measure those cost savings. So, this is going to be a big leap for the actuaries, because what we're essentially saying is you will get paid if someone's A1C improves, or if their blood pressure improves, or if their weight improves, or if whatever the measure of the program is improves. And they have so the question of whether and how it saves money is going to be one that's very difficult to analyze and interpret. I personally don't go into this worried about the program not lasting. I don't worry about, I go into it with a sense, and I think we should all go into it with a sense of optimism that people will figure out how to make it work. And, I think we're always looking in healthcare for that, that underbelly. And there will be challenges. There will be potential for fraud. There will be potential that some things will, appear to work but not save money and so forth. But, at some level, you have to essentially take a leap of faith and say, we have got to invest in prevention. We have got to invest in people managing their chronic conditions. And if we do that, that leap of faith will pay off, and that we'll have lower downstream costs. So it's a gamble. It's a bold gamble, but I think it's a gamble that everybody in the healthcare system believes it's time we make, or many do.
Rebecca, since we're the cynical journalists here, we do have a audience question that is kind of the flip side of Andy's optimism. What are the most pressing concerns that regulators and the public ought to have? You've talked to dozens of people for these stories. Have you heard any concerns?
I do think there are concerns, as there is with any kind of large program and any kind of big change like this. And I think with AI generally, there is always concern about security and privacy. There are concerns, how do you measure the data? How do you validate it and make sure that the outcomes are what we think they are? There also are questions about safety. I mean, some of the folks that I talked to who are interested in this program offer virtual therapy. And of course, there's been a lot in the news about concerns related to that. If you're talking to a chatbot, and there have been instances and there are lawsuits pending based on people who have committed suicide, sadly, or committed violence after dealing with a therapy chatbot. So I do think there are concerns that will have to be worked out with this program.
Mm-hmm. And Andy, sort of following up on what both of you have said, there's an audience question about outcomes. Do outcomes include clinical quality outcomes only, or will financial savings in and of itself also be in play for the Access program?
Well, again, we're waiting for more details, but right now the outcomes appear to be entirely based on clinical guidelines. So that means, blood pressure. That means A1C. That means weight loss. That means any one of the number of markers that can be measured through a laboratory or otherwise. And I think they're taking on faith that they're going to have that's going to result in downstream cost savings. So it'll be really interesting to figure out how they value that and how they pay for that. But it is very much focused on improvements in quality, and importantly, it's at the individual level, not the population level. So it's not like they're saying, as they do with other value-based care models, take 1,000 people, and on average, you've got to show improvement. What they're saying is, on a per-person basis, they've got to improve from their own individual baseline.
That's so interesting. And I wonder, can you kind of clarify, maybe we talked in the rural example, these are states that are each setting their own criteria for how they're going to dole out the money. Can you talk about how that works for Medicare? Who's making these decisions? Who's writing these guidelines? How much transparency is there? Same questions that we talked about before. Can a member of the public read these rules? How can companies access this information if they're interested?
Well, I expect CMS to put out a series of documents outlining in more detail how it will work, and then there will be an application process, and people will apply directly to CMS, to the group that Rebecca identified, CMMI, the innovation center within CMS, who will evaluate these programs. And in order to apply, people have to be registered as a Part B provider, Medicare Part B provider. So if someone is interested in saying, hey, I have a technology or an application or a wearable or something that can improve people's health, they can apply to this they can apply to, first of all, be registered with Part B, and then they can apply to CMMI and then find out whether or not they're approved. And if they are, they'll be in a directory that physicians will be able to access and Medicare beneficiaries will be able to access.
Excellent. And we have a related question from an audience member. How can a university public health department participate in the program?
That feels like a Rebecca question.
I think that's an interesting question. I mean, because as Andy just said, you have to be a Part B provider or supplier, so you'd have to register that way. And certainly universities are doing innovative things and working on technology, and you could go through that process if you can become a Part B provider, and you could submit your application and see what the Innovation Center says.
Mm-hmm. Oh, great. Well, I'd like to turn now to talking about how industry is responding to these very strong demand signals being sent by the federal government around technology and AI. Andy, talk a little bit about what's going on in the health tech industry, where you see some of this innovation potentially bubbling up the most, and is there anything out there that particularly excites you, or that you think this is really a potential game changer?
Well, we're in the midst of a boom in healthcare AI. Investing in healthcare AI technology is already off the charts, and this is going to stimulate, even further focus on things that are really individual patient and consumer oriented. So, there's been a tremendous amount of funding in the venture capital industry for all kinds of companies that are focused on using AI to somehow streamline and improve the processes in healthcare that are so frustrating to so many of us. And indeed, generative AI does a pretty good job of helping make sure that our physician visit, that a company like Ambience Health can make much simpler. That the prescriptions that we get access to, like a company like Arene Health, can improve upon. That almost in any part of the healthcare system, from how you get your medicine to where you end up deciding to get care, to your mental health care, has some form of AI application or technology company that's running at it. So I think the people won't be starting from a dead start when they start to look at these situations that are available now through this access model, because there's so much that's been built, and I think people are really going to evaluate whether or not they can participate in this program. Already, we've seen 250 or more, 250 and counting as of last week, companies express interest in participating. And I expect that number to grow much, much higher than that.
Do you see any particular opportunities where maybe there's a white space that has not yet been filled, or sort of what's like the next area coming over the horizon that you'd want to draw people's attention to?
It's a great question. It's a really great question. I think, I mean, in some ways, despite what I just said, I'll contradict myself a little bit. I think it's all white space because this is brand new. And so I think we will see all kinds of new things pick your area: heart disease, cancer, kidney care. There's companies doing remarkable things in kidney care, like Strive Health, that can provide more prevention capabilities. And this is essentially going to challenge all those companies to say, can you go upstream and help people so that they don't get sick in the first place? And I think that's really the challenge of this administration, and what I think one interpretation of what MAHA, Make America Healthy Again, means in the CMS context is indeed prevention, wellness, and chronic care management. Can you prevent people from having breakthrough illnesses? And I think, to be honest, it is nothing but white space. That's the mess we're in. People get sick in this country. They get multiple chronic conditions. They get sicker and sicker, and they live with more and more chronic illnesses. So the challenge for companies out there is to say, if you have the ability to use technology or wearables or something to make a difference in those conditions, now's your time.
That is really inspiring, and I really hate, Rebecca, to always throw the Debbie Downer questions at you, but that's just the way this has been working out.
He's typecast, Rebecca.
And Rebecca's a very uplifting person, I should say. But there are always flip sides and nuances to these. So in researching your reports, you found that a number of the key people crafting these very pro-tech, pro-AI policies in the federal government came from industry themselves, which on the one hand is a really great background to have, but at the same time that has raised some concerns from people that you've talked to. So talk a little bit about kind of who's making these decisions and what are some of the things that we should be, as an informed public, keeping an eye on?
Sure. So when the question came through about the 10-year time frame, I thought that was interesting because it is unusual to have a 10-year time frame for one of these models. But I'm also, I don't think it'll be cut short either. And it's been interesting to think about the fact that so many of the Trump administration officials do come from the healthcare, tech, investing, or business world. And as you mentioned, in one sense, that's great that they have this familiarity with this space and they know how to navigate it very well. But I think there is a concern that several people raised with me about the revolving door and the fact that, you can apply to be part of this program as late as 2033. And what does that mean? And so there were some questions raised about the structure and the background of the officials who are putting it together.
Andy, we have a question from the audience that maybe I'll throw to you. While the federal government is promoting AI use and investment in AI within states and programs, do you see CMS itself using AI in their role as program administrators and through their contractors supporting programs? And if so, how?
Well, it's interesting. They did talk a little bit, and I don't know firsthand the answer to this, but they have been speaking publicly about across HHS, Health and Human Services, how they're going to use AI much more to in their own operations, and that was a part of their rollout announcement. And I think they're going to use AI everything from fraud detection to reducing prior authorizations to building directories of physicians for patients and consumers, to moving towards real-time payments, which is sort of always been this long-term goal of Chris Klomp, who runs the Medicare operation for CMS for Dr. Oz. So, I think that this is a technology forward group. It's a very, very antiquated set of systems that they live with today. So, it's easier to say than to do, but, this is a group that seems to be leaning into using AI and everything that they can find.
We have another question here that is kind of related to the broader use of AI. Beyond wearables and other consumer-facing tools, how are providers using AI on the delivery side within clinical operations? For example, in risk stratification, care management, or resource allocation, to advance value-based care. And I think that's so interesting because I feel like we've been talking about value-based care for a long time, and I wonder if this is sort of going to be a turning point on value-based care. But do you see AI making a difference at the provider level, as the person is asking?
Oh, no question. And I think value-based care really enables people to think out of the box and use technology differently without worrying about how it's going to negatively impact them from a payment standpoint. But one of the best technologies is the technology that is now commonly used to scribe what goes on during a doctor visit, code for that visit, provide intelligence to both the doctor and the patient about what goes on in that visit by ambient listening. And I mentioned this company, Ambiance Health. They are one of the companies that is really pioneering this, and it's transforming the physician experience because the physicians can, rather than what they've had to do, which is historically kind of read a file, go in, take notes on their computer while they're talking to a patient, then do a bunch of coding afterwards and do a bunch of follow-up notes, etc. Ambience technology does all that stuff for a clinician, and that's a game changer. And it allows physicians to focus on the patient and getting to outcomes. And it seems to be really popular as this kind of technology has been implemented.
Rebecca, obviously we're seeing play out not just in healthcare, but in absolutely every place where AI is being used or contemplated. This tension between, on the one hand, government wants to encourage innovation, but on the other hand, are real harms from technology of various sorts. You mentioned privacy. There's other concerns people have around AI that require regulation. We're now seeing this standoff between the federal government signing an executive order saying states can't regulate. States, we've covered just the profusion of AI regulations that different states are either putting forward or working on that cover all kinds of different use cases and aspects of AI. So we have an audience question asking, who should create AI guidelines for providers? And I'm wondering what you're seeing so far on that front. How is that being approached, either in the states and rural health case or in the Medicare case?
So these are early days, but we have seen some things develop. In 2018, the American Medical Association put out some guidance for its members, and they've continued to add to that. We've seen the World Health Organization, I think it was in March, put out a document related to AI and tech and healthcare. And of course, the FDA has put out several guidance documents, starting with the first Trump administration and then continuing on. But there is a lot more that has to be done. And of course, regulation also has to keep pace with technology, which is moving at lightning speed. And so I think it's a real challenge to see how that tension, as you mentioned, is going to be handled, because I mean, things are changing so quickly. I don't think the government can stay ahead of it.
Mm-hmm. Well, in every briefing, we make a point of looking ahead. And so I wanted to start with you, Rebecca. Talk to us a bit about what you're working on for subscribers and what you're following over the next couple weeks and into the new year.
Great, thank you. So my next report, which comes out Tuesday, is going to be talking about healthcare inflation. We have heard a lot about how the ACA, Affordable Care Act, tax credits are expiring and how employer-sponsored insurance premiums are going up. So what's behind that? What are the underlying factors affecting the cost in America? And so then we'll also be releasing the transcript of my interview with Seema Verma. She's a former CMS administrator as well. And some other things that I'm interested in looking into include prior authorization and how the Medicare market is changing.
Excellent. And Andy, what are you working on next? And how are you seeing sort of the coming year?
Yeah, I mean, what I'm really focused on is trying to figure out how we can use AI to close some of the gaps that exist between the haves and have-nots in healthcare. Oftentimes, as we get new technology introduced, that new technology benefits people who have the best access to technology, and as a result makes the gaps wider. And whether it's rural versus urban, where the life expectancies are so much shorter in rural America, or whether that's people with lower incomes or with race, gender, ethnicity, whatever the difference may be. We have got to use technology to allow it to get to places where people need it the most and where people don't have access to physicians and clinicians. So we're looking at a series of investments now that I think should hopefully serve those types of communities where people are not getting access to care, and where AI and technology can make a big difference. And that's, I think, going to be a big focus of ours in 2026.
Mm-hmm. And for both of you, what are other CMS regulatory changes or innovation models that you're watching for going forward? Obviously, we're in a moment of great ferment and disruption. What should our audience be keeping their eye on next?
Well, some of the things that we're waiting for are, we're waiting to see if there will be any additional work on drug payments and innovation model projects with that. There are several things that are in the works, and we don't have the details yet, but we're watching. But maybe Andy can tell us more.
Well, I think the biggest program in value-based care right now is called ACO REACH, and that expires at the end of 2026. And I think there's been an open question as to there's things in that program that it was put together in the Biden administration, and there's some things in that program that the Trump administration clearly doesn't like. And so the question is, has always been, and I think remains, what happens with that program at the end of 2026? Does it change? Does it evolve? Does it end? And I think we're getting signals that it will evolve, that the people in that program will indeed see a successor program to it that looks different than ACO REACH and is called something ACO REACH, probably called something a little more Trumpy, and will have access to a model that will look a little bit different. And I think there's a lot of curiosity, and I have a lot of curiosity on what those differences will be. But the themes of this administration so far have been prevention, health, wellness, chronic care management, kind of MAHA. And so I expect to see those types of features as we see the successor to ACO REACH.
Excellent. Well, thank you so much, Rebecca and Andy, for joining us and for sharing so much of your in-depth knowledge. Obviously, this is an issue, AI and technology, which we will continue to cover closely at WP Intelligence and its intersection with healthcare in particular. I'd like to remind our live audience that you can request a WP Intelligence platform demo by clicking the link on your screen. And please block your calendar for Fridays at 11 a.m. Eastern. That's our regular intelligence briefing slot. And I will be back next Friday with our lead analyst for global security, Josh Rogan, and we'll be breaking down the latest on the National Defense Authorization Act. And in the meantime, we'll send our live audience a link to a recording of this briefing. And we ask you to please take a moment to fill out the short post-briefing survey. Your input is closely read and shapes what comes next for us. So thank you so much. Have a wonderful weekend and see you next Friday.